Hello and welcome to HFMA Talk, the podcast for NHS Finance. I'm Lisa Robertson, a Policy and Research Manager here at the HFMA. In this podcast, you can hear the full conversation had on the role of the Integrated Care Board and how this fits in with the Integrated Care Partnership, provider collaboratives and place. This is a supplementary episode to the podcast covering the introduction to finance as the Health and Care Act comes into force. As introduced in the main episode, I'm joined for this conversation by Lee Outhwaite, Jonathan Webb, Zoe Petriarch, Carolyn Wood, Mark Bakewell, Nikki Briggs and Sheila Stenson. So I want to start today by thanking all of you who have joined me today to share your thoughts and experiences. So let's talk a bit more about the role of the ICB and how this would be different to that of the CCG.
I guess what each ICB is grappling with is if we're transcending that old commissioning and provision split, what the four component parts of the integrated care system do and how the accountability model works. So there will be powers that will be retained by the ICB. There will be things that will be discharged by a provider collaborative, which is providers working jointly together in a way that is made more possible by the Act. There will be a place-based collaboration, which in some of the bigger ICBs who've got identified places linked to upper tier authority, there'll be a place-based collaborative. And in addition to that, there'll be a broader health and care partnership where we bring together local government and the voluntary and social care sector. And I think in reality, everybody is currently grappling with, in that new architecture, with a bit of precision, who does what around here. So is the ICB a great big blooming thing that's all encompassing, that does everything? Or is the ICB something that facilitates the provider collaborative, the place-based collaborative and the health and care partnership to really go away and work differently together in a way that's made possible by the Act? I'm beginning to see this role very much as a system convener role. So South Yorkshire is quite a large ICB. It's got 4 discrete and discernible places in Sheffield, Doncaster, Rotherham and Barnsley, which link to a metropolitan borough authority. So I see my role trying to facilitate that place-based collaborative working in each of those 4 places with a changing role for each of the provider DOFs. So I'm trying to work out what's the job card for the provider collaborative that's best delivered through the providers operating collaboratively. What's the job card for the place-based collaboration, which is a slightly different thing about population health and changing and integrating care, versus the things that are retained to the ICB. And I think we're all thinking that through, and the Act's very permissive about how those different 4 bits of the jigsaw join together: ICB, provider collaborative, place collaborative, health and care partnership, which is very positive. But we perhaps do need to think about what are the principles for the work to be done and where they sit in those 4 component parts of the new architecture. And I think national colleagues and others would say, and they would be right, how mature each system is, its history of collaboration, its geography, the people involved, the skills and strengths are all different. So it's entirely possible that people will come up with different conclusions about how they operate through that 4-point model. But I do think there are some principles that we need to nationally adopt about who does what around here. But certainly, I think finding our way into what are the distinct and different roles and responsibilities is really important, because there's an enormous job of work to do in terms of delivering a more sustainable health and care system. I think the broader impact that will come over time about how we do deliver more seamless and different health and care services for the populations we serve actually sit in that non-statutory structure of the integrated care system. So there's something about these are absolutely the things we've got to do as an ICB in terms of statutory duties, our fiduciary duty in terms of use of public funding. But in actual fact, my personal belief is the things that will make a real difference is how do we work more broadly through that health and care partnership that includes local government colleagues, it includes the voluntary and community sector, it includes in the context of anchor institutions, local employers, and gets into a quite different space about broader health and well-being than that historic space that you could contend the NHS has traditionally operated about being a bit more of an illness service. The thing that I'm doing at the moment is really trying to think through what problems are we trying to solve, and how do we describe that? We almost need, I think, an elevator pitch as each ICB that says what we're about and what we're trying to change around here are these following things. But there is a way, I think, to try and split up the work to be done that transcends individual organisations, perhaps primary to secondary care organisation, health and care integration, and an integration between health and wellbeing and illness services that will get us into a more sustainable place.
I think I'd probably stick to about 3 key points. First, I think that the mandate and accountability is different between CCGs and ICB. So there's a requirement for a kind of financial stewardship role across the system, including financial performance and that kind of accountability without having the direct responsibility. And it's particularly that accountability part that wasn't necessarily there in the CCGs. The second difference for me, I think, is the way that accountability is discharged is very different between the CCGs and the ICB. And I think that the ICB kind of board level are much more like a provider organisation rather than just the CCG, but it's going to be effectively less member focused and more managerially led. But obviously the third point is that board is going to be extremely different. So we're now having to manage in a in an arena and an environment where partners are on the board. There's shared responsibility for obviously the health of the local population, which it's how that manifests itself in a board level. And obviously there's going to be representatives on behalf of the sector, not just the organisation that they support, which I think is going to be really interesting for those partner organisations and how they play that role through, particularly when it comes to local authorities and other members that aren't used to being part of NHS boards.
There are different tiers at which decisions can be made, and there are certain decisions that are best made at a very sort of local level, neighbourhood level, primary care network level. There are other decisions that are best made at place or at system level. And for us in system, we're a big system. That's West Yorkshire. There are certain things that it is more appropriate to be done at a system level, and that might be about doing things at scale. It might be about dealing with issues that have been problematic for a number of years, or it might be about sharing best practice.
Can you explain the difference between a clinical commissioning group and an integrated care board?
I mean, there's a technical difference between the two. So ICBs or integrated care boards, there is one per system, whereas in some systems currently, before the 1st of July, there are multiple CCGs, so it'll bring those CCGs together. And there will be less GP involvement within ICBs as opposed to CCGs. And from an ICB perspective, there will be more services delegated, which it makes it very helpful to align the patient pathway. So we'll have some of the services that are currently commissioned by the region and by the national team delegated out to our ICBs and out to our systems. I think the really big difference, it's kind of the technical side of it. I think the really big difference is the behavioural difference. So ICBs working at a system level, bringing in other partners across the system, NHS and non-NHS. So I think it's a hearts and minds behavioural piece, which is really important there. And it's about the relationships that the ICB will be able to build. I think it's really important part of the new legislation in that the ICS duty is break even, so that each organisation has an interest in the overall system position, not just a siloed interest in their own organisation position. The really important role of the ICB in this, I see, is that they need to understand the financial performance of each of the organisations, consolidate that up to an ICS financial performance position, but also really importantly understand the risks for each organisation and what the mitigations might be, so that if throughout the year that position goes off target, there is a process to be able to get it back on track.
There's still going to be commissioning that's going to be done by the ICB, but it's got to feel different to how it did from the approach from the CCGs. It's got to be a lot more about collaboration and working together, and less about competitive nature that's been part of the NHS for the last 15 years between providers.
There are a range of things and duties that the ICB will have to deliver, which will be very similar and equivalent to the CCG landscape. So that's definitely something that will be the same. I suppose the other key difference is the size and the scale of what that organisation will be. So again, for us, moving 9 different organisations into one being, and the challenges of consistency of approach across those 9 footprints into now one. So a simple policy about a certain area of commissioning expenditure, for example, we need to be consistent on that now across our sort of constituent parts, whereas previously, because they were different statutory bodies and had different processes, you could have a little bit of variation. In terms of opportunities, I suppose what you'd argue is the scale that organisational change brings. So where previously you've got pockets of really good practice in each of our 9 CCGs and places, we're hoping that the scale of opportunity that presents itself in terms of economies of scale, and where we've got good practice in one part of the system, the ability to lift and shift that into and across the sort of the new organisation hopefully will be easier. Obviously, at the moment, you've got 9 different ways of doing things, 9 governance processes and boards, and different stakeholders are all involved in that. And hopefully, by having one approach, the aim of that, I suppose, the opportunity is hopefully to improve outcomes, which is obviously what part of the founding principles, really, what the ICB and ICS is about. So reducing variation, looking for consistency of approach, and again, we know that there are lots of really good examples of clinical practice and programs of work that again are being done locally, and again hopefully the scale will bring that through. And I suppose the other opportunity we would hope is actually delivering upon reduction in inequalities by working with our partners, particularly our local authorities and voluntary and community organisations, to help tackle some of the real difficult challenges that we have. That ICS principle of bringing together all those different agencies to try and improve outcomes, reduce inequalities, and hopefully financially make a case for making the money work, I think is what we're aiming to do.
And how do you think integrated care boards and integrated care partnerships will work together?
Yeah, I think it's a bit of an unknown, isn't it? And I actually think it will be different depending which system you're in and how each system adopts it. And I have a view on all things ICB and ICP that how we set things up in the next year probably won't be what it looks like in years 4 or 5, particularly as we start to establish things like place and that kind of place-based leadership, delegation, and obviously all the provider collaboratives. So I think that everyone needs to kind of give themselves a bit of a break. It's rather than waiting for everything to fall into place and having all of the governance arrangements ready, how do you start to work together? How do you look at those principles of partnership, which is obviously what the ICP is about, around integrating services? And I think some of it is very simply, how do we share all of the information that we've got, and I think the ICP has got an opportunity to bring that longer term focus.
From an ambulance trust perspective, I see the ICB being that statutory NHS organisation within the system, with the remits to commission and secure services for the population. They'll also take advice and views from the provider and other representatives on the board and within committees of the board, whereas the ICP is where the main partnership working will happen. And that will start to bring together all sectors within the system, including social care and also, of course, the voluntary sector as well, and how all elements can work together for the needs and the direction of travel for the board. The difficulty we have is that each ICB can determine the part we play. We're recognised as a key regional provider across, from a northwest perspective, across 3 main systems, but also 2 places. But each ICB may have a different approach and therefore different views in terms of how we can play into the new arrangements. And based on the guidance out there at the moment, we're expected to be a partner of multiple ICBs, but again, we're not sure how that looks and what that will mean. What we also need to consider is how we can work with these new arrangements across the patch, because there's going to be several key meetings and forums which we need to engage with, but there's only one of us and one organisation. So it's how we can service all those meetings, making sure we've got the right representation and decision makers that can support the wider systems and the ICBs as well.
I think it is something that's going to evolve, and in some of the conversations that I've had previously around this, I think there is a concern, or has been a concern about making sure that those 2 forums don't duplicate each other. So from an ICB board perspective, the ICB will be deciding how to spend the money to deliver the best quality health for their population. I think the ICP, Integrated Care Partnership, will be working at a more partnership strategic level to make sure that all system partners are joined together in steering where that funding is spent and where it's best for the population.
In West Yorkshire, we've actually got some experience of something that's hasn't been called an integrated care partnership, but it's something that looks and feels and sounds incredibly like an integrated care partnership. So we've had a partnership board that's met in public on a quarterly basis, probably for about 3 years now. And that partnership board has been made up of council leaders, chairs of health and wellbeing boards, council chief execs, chairs and chief execs from all the local NHS organisations, with a range of supporting bodies, voluntary community sector, Health Watch, etc. So we've had a partnership board in place that's overseen, approved, brought together the West Yorkshire strategic intentions. So that's already existed for us, and I think that strategic body has helped shape our strategy. Has certainly put some constructive challenges along the way to make sure that we do look at that broader picture around wider determinants of health, making sure we do bring in that broader picture around the sort of the inequalities that exist in our societies across a range of different factors. It can work. It has worked. It is very much about that principle about subsidiarity, the makeup of the West Yorkshire. It's a symbiotic relationship between the things that will happen at West Yorkshire and the things that will happen in places, as expressed through the health and wellbeing strategies across our 5 places and the strategy across West Yorkshire. I think the thing that made it work was to be inclusive from the outset, and to meet in public from the outset. Start as you mean to go on, be open, be transparent, be inclusive. The challenge, as ever, in a system where money is constrained and short, is ensuring that we do something about it. What we often see is health inequalities funding being non-recurrent, being discretionary, and having lots of conversations about sometimes fairly sort of small pockets of money. Whereas the challenge is not only to ensure that we do ring fence some resources, I think, for some, this really important agenda, but we also influence about how our baseline funding is spent, and it goes into the right places, and it goes into that more preventative upstream type work, and it's focused on the right neighbourhoods and areas. Probably more thinking about a medium term, short to medium term type basis. So you might start to think about the provider collaboratives, both across systems, but also vertically into places. So through secondary care, through primary care, through community care, and through social care, and really start to think about how those providers are starting to work together to look at their resource in totality, to, I suppose, have a different conversation, change the dynamic about how those resources are deployed. It's not just about accepting the status quo, it's very much about saying, well, this is the pot of money that we've got to spend on a particular patient pathway or a particular sort of, disease grouping. How are we as a set of providers going to deploy that money in a different way to not only, I suppose, treat the symptoms, but also treat the cause, because it's the cause of health inequalities that is the issue, and that might get into not only encouraging other agencies to deploy their resources in a different way, but also looking flexibly about how we deploy our own resources.
There's a real need to, I suppose, to work this through as part of ICBs in the next 12-18 months. Certainly locally, we are looking to empower our place and our place leads because they will be closest, if you like, to the local patient flows, local systems and understanding of needs. I think for me, the differences are you're going to, in terms of collaboratives, they are about providers working together to achieve the outcome or achieve the same goal. They may, deliver services to different parts of that overall patient pathway, but, we need to encourage and stimulate them to work together, to collaborate, to deliver that sort of the outcome that's required. Place is slightly different because in effect the place is a subset of the ICB, so in effect we'll receive a share of the overall allocation, and I suppose the question is how can we empower place to deliver those outcomes and understand what's needed. So asking place to understand their local population, what's working, what's not working, what needs to be done differently with the providers in that system. And I suppose inevitably then the place is working with the provider collaboratives to distinguish, well, that may work really well for that particular place, but actually that's not going to work for us over here because we've got different demographics or different inequalities or different access type issues. So really, place for me personally is about the understanding of the local population and what needs to happen to sort of take place. And again, it's about the levels of delegation. So certainly in Cheshire Merseyside, we're looking to devolve as much as we can down to place level because we think that's the best position for the resources to be sort of evaluated and used effectively. And we'll need them to work hand in hand with the provider collaboratives and obviously as part of the wider ICB system then to deliver on those outcomes.
And again, it's a really tricky one because the provider collaboratives are there and they're working together already. Primarily, it's the acutes, the mental health and the community side of things. And at times, from an ambulance perspective, and this is from my personal experience, we're on the periphery of that. There will be some elements where absolutely we can collaborate with colleagues in the system, but I think that's going to be some of the more generic corporate services, so the corporate services, the back office services. So absolutely collaborating with them there. We also need to be part of that collaboration as they start to look at some of the system changes or clinical changes. If there's a clinical pathway change when they're starting to work together, will that have an impact for ourselves in terms of moving patients around, transporting patients? So it's good to be tied in because there will be an impact for us as an organisation. I think it's also important for the places as they start to form to be knitted in with the system plans and the wider strategy to make sure you have that clear communication and clear framework of the expectations at place versus system versus the wider regional and even national requirements, bearing in mind that for some of these things we're working across different populations, across different footprints as well.
We are quite keen in West Yorkshire to retain a link between how the money comes into West Yorkshire and how it gets distributed to our 5 places. Part of that is because we've got 5 established subcommittees of the board, which will be our 5 place committees, who have the responsibility through our scheme of delegation for deciding how that money is dispersed once it gets into place. But we're keen to ensure that the way that money is allocated into places does follow population need. So what we are not doing is following verbatim the way that NHS England would have distributed money into CCGs pre-ICBs, but we are looking at by place for that population that exists in each of our 5 places, how the population health need as determined by the national formula that says for this particular cohort of patients with this particular demographic, this particular age, this particular levels of deprivation, this is the amount of money we think, say NHS England, you should be spending in your place. NHS England deliberately and consciously stop at ICB level, but we've used that data to drill down to what it means by place. And in 22-23, we have reconstructed, if you like, what it looks like in terms of is a place spending more or less than its target allocation. And we've made some very small adjustments to around the differentiation of growth into our 5 places to recognise that some places are spending more than their target allocation and some places are spending less. In terms of how we made that decision, we make it by consensus. So we haven't had a statutory finance committee or a statutory board to determine what that policy has been. But through the 15 directors of finance and the chief finance officers that get together on a monthly basis, we've collectively looked at all the various options, looked at all the various permutations, the various ways that we could have distributed our resource, and through consensus we've determined that's the most appropriate way to do it. So I think we've got a different model in West Yorkshire than I understand developing in other ICSs. So what I understand in some other ICSs is that there'll be, if I take the acute hospital sector, the commissioning responsibility and therefore the money flow for acute hospital spend wouldn't flow into places. In effect, would be dealt with, addressed, planned, managed at a system level. So there'd be a contractual relationship between the ICB and either the provider collaborative as some form of entity, or I suppose as some sort of vehicle for accepting resource and then distributing to the acute providers in that particular system. And what's been really clear from day one in West Yorkshire is that we didn't think that model made sense for us. We wanted to ensure that places had the resource allocation for in-hospital care and out-of-hospital care. And because that's the case, we don't see any financial flows in terms of ICB commissioning of healthcare expenditure, healthcare services going directly from the ICB to the provider collaboratives as a principle. So it'll go through the places.
The conversations that we've had locally and I've had with other colleagues across different systems is the first port of call is how quickly do we delegate, rather than actually what are you delegating. So I think there needs to be a real focus on what you're trying to do, what the scope is for either the collaboratives or the place, and therefore what then. I think the first step is what's your understanding of the finances. So start by reporting and understanding the costs before you get to kind of the full delegation, because what we don't want to do is jump straight back into creating through place CCGs again, and re-establishing that. And I think for me the key to that is really the understanding of what you spend, and also a recognition there is not new money. This is money that is already spent with providers, with other organisations on contracts, etc.
For us, as kind of the trust that I work in, we work across the whole of Kent and Medway, which means we've got a place around every single of our ICPs, and we've got 4 in total. So actually it's about how we get our voice heard for mental health across the system, but 4 times over in the different kind of ICPs as well, but with the ultimate aim being that we have, equal care for our patients across all of them ICPs, because what you don't want to end up with, and I hate this term, but it's a postcode lottery. It's got to be, it's got to stay consistent and have the same care for patients. So I think, the place stuff is all evolving. In terms of provider collaboratives, we've got some really good experience from this from a Kent and Medway point of view, because we've been part of the forensic and Sussex provider collaborative, which has probably been running in shadow form for about kind of 2.5 years. And then we've just done a full year where actually the funding has transferred from NHS England into the collaborative, and the host is Sussex. So, and we've just had a really, really good kind of year in terms of performance from not just the patient point of view, but in terms of kind of quality for the patients as well, and the care we're providing, but also from a financial point of view. And we've had a board in place probably for the last 2.5 years, even when we were shadow running, which I'm a member of. And we've got different people that are coming together around the patch, but it's not just NHS providers. We've got non-NHS providers around that table, around our board as well. And then we've got a series of kind of subgroup stroke committees which focus on quality and also focus on performance and also focus on finance. So that traditional structure that you would see, which is there's a board and there's subcommittees, still exists, even though it's a provider collaborative. But it's bringing different kind of parts of the sector together to kind of, think about what's our ultimate goal here and how can we deliver better care for our patients.
Thank you for listening to HFMA Talk and this supplementary episode to our main episode on the introduction to finance as the Health and Care Act comes into effect. Don't forget to subscribe to this podcast to keep up to date with new episodes.